thanks everyone for joining. My name's Tom Fredrickson. I'm the System Vice President for Hospital Medicine Operations, and I'd like to welcome everyone to Hospital Medicine Grand Rounds this afternoon. We have a really great topic. Our topic today is patient capacity, and we have some very wonderful presenters and panelists. I'd like to introduce you to them, and then we'll get going with our webinar. Our first presenter panelist today is Dr. Temple Anzalone. She's an assistant professor of medicine at Creighton University School of Medicine and a practicing hospitalist. She would say that she bleeds Blue Jay Blue since she went to Creighton for undergraduate medical school as well as internal medicine residency training. Since completion of training in 2004, she's been a clinician educator at Creighton as well as the Omaha VA. She has three main passions: teaching, patient care, and patient safety. And this topic, she says, is near and dear to her heart, and we're very glad to have Dr. Anzalone with us. The second is Leslie Kuhnel. Leslie is also Dr. Kuhnel. She's PhD Dr. Kuhnel. I guess PhD candidate. She's completed her PhD. Sorry about that, Leslie. So Dr. Kuhnel is the Division Vice President of Theology and Ethics for the Midwest Division of Common Spirit Health and part of the National Common Spirit Health Ethics team. She provides leadership for various healthcare ethics initiatives, facilitates several ethics committees, including specialty committees in behavioral health. And for Critical Access Hospital, she serves as the primary ethics consultant for the region, and she conducts numerous educational programs for all kinds of different healthcare professionals within our healthcare system, as well as in the community. She completed her doctoral degree from Loyola University, Chicago, Masters of Science in Ethics from Creighton, and Masters of Public Administration from the University of Nebraska, Omaha, and she's certified in healthcare ethics consultation. She has areas of interests, including the care continuum, end-of-life care, advanced care planning, advanced directives, diversity and cultural humility, serving vulnerable populations, and healthcare access and equity. Our next panelist presenter is Dr. Jennifer Osborne. Dr. Jennifer Osborne is a palliative care and hospice consultant, and she's also board certified in both hospice, palliative care, and internal medicine. And she works at Mercy San Juan Hospital or Medical Center in Sacramento, California. She runs the inpatient palliative care service there. And she's also an internist and has a number of years of experience as a hospitalist as well. Our next panelist presenter is Dr. Megha Shah. She's our medical director and also a hospitalist at St. Joseph's Hospital in Tacoma, Washington. She also has a fellowship training in nephrology from Johns Hopkins, as well as a master's in medical management from Marshall University. She's a certified ethics consultant through the American Society of Bioethics and Humanities, and she also is a currently practicing clinical ethicist. Her special interests include conflict resolution and consensus building. So we have a great panel. Just one final note before we start the webinar and turn it over to Dr. Anzalone to kick us off. If you have questions, please put questions in the chat or the Q&A. There'll be some polling questions throughout the presentation, but then at the end, we'll have questions and answers for our panelists. So with that, I will turn it over to Dr. Anzalone and the rest of our panelists.
So I am Dr. Temple Anzalone. So I work primarily as a hospitalist. I work in Nebraska, and of course, this is a nationalized meeting, and I'm glad we have other people on the phone that can speak to how things can vary a little bit state by state. But yeah, so I work primarily in Nebraska, and what we're talking about today are issues surrounding patients' capacity. or patients who don't have capacity to make medical decisions. So here are our objectives. You guys can read, but basically the first is making sure people are comfortable and confident in doing a capacity determination, making sure providers can then use that information in helping make decisions for patients who lack capacity, and also apply those tools and resources that we'll give you towards the end of the presentation when encountering difficult capacity related cases. So for those of you who've done a lot of hospital medicine, you realize we come across patients who do not have capacity to make medical decisions quite a bit in our practice. This was a 2011 statistics that 26% of medical inpatients don't have capacity to make medical decisions. I would venture to guess that that number may be higher, unfortunately, and realize that 80% of ICU patients have delirium during some point in their stay. So I'm going to start off with some scenarios. Some will be more acute, some will be more subacute. But before that, what drove me to want to give this presentation, I guess, I gave this presentation as a grand rounds just at Creighton University for our students, faculty, and residents. And it was because of all of these issues that just kept coming up. Patients that don't have capacity, who want to leave against medical advice, those that refuse treatment. So it kept coming up over and over again. And what I found, at least in my hospital, was there was a lot of confusion in how we handle these things, from the nursing staff to even some of some of the more seasoned physicians, if you will. And I feel passionate about it because as of next year, I'll have been a teaching physician for 20 years. And I feel like this is such an important topic from a patient safety standpoint, from an ethical standpoint. And it's something that I try to teach my students and residents. And it's not always black and white. And I think that's why, why we're having this presentation, because these can be very difficult decisions to make. So again, there are a lot of different issues that come up, and speaking from the inpatient hospitalist internal medicine standpoint, but the big ones are, one, just feeling comfortable determining capacity. The next is, what do you do with that patient who wants to leave against medical advice? What about consents for patients that lack capacity? And then the final big one is those patients that don't have capacity who refuse medical care, and how do you handle that? And so this first case was probably the most dramatic. and again, when this case happened with several prior incidents, is when I decided, okay, this is a big topic that a lot of people don't have a firm grasp on, and we really need more education on this topic. So without further ado, all of these are real cases. Obviously, for HIPAA reasons, I've changed names and a few of the details, but these are all real patients. So Mr. Jones, I think there's a fly in just a second. Oh, there we go. So he's a 56-year-old male, no known past medical history. He was brought in from the local homeless shelter with confusion and fever. I was asked by the emergency room to admit him to the hospital. He was noted to have severe sepsis. He had a left lower extremity cellulitis that was progressing very quickly. And clinically, we felt he had necrotizing fasciitis. So infectious disease and surgery were consulted, and they recommended that he be taken immediately to the operating room for debridement and most likely an amputation. We were trying to get a hold of next of kin because there was concerns that he may not have capacity to make these decisions. And when we went in and talked with him, he basically said, What he actually said was, I have a machine gun and I will shoot anyone that tries to take my leg. So very dramatic and kind of an uncomfortable situation for everyone involved, especially the surgeon who was going to be doing the procedure. So obviously at this point, we needed to do a further capacity assessment and really see, is this a guy who can actually give informed consent or not? And if not, what do we do? So he, when asking him to articulate back to us what his diagnosis was or the ramifications of not having surgery, he was unable to do that. When asked why he didn't want to have surgery, he says it'll just get better. It'll heal on its own. When told that he will likely die if he doesn't get the surgery, he says, I'll be fine. I'm not going to die, but was unable to further expand on his reasoning. So here we have a polling question. All right, so what is the next appropriate management step? So A, take to the operating room and perform amputation if necessary. B, get an emergency surrogate decision maker as appropriate to give consent. C, abide by the patient's wishes and not pursuing surgery, or D, obtain an emergency ethics consult. All right, so we'll have folks place their votes. Okay, very good. Oh, I love it. I love it. I love it. So we got a little bit of everything, and the biggest one was obtain an emergency ethics consult. So that was what I wanted to do, and what I found out was at our hospital that wasn't going to happen in the next few hours, and probably not for a day or so. And so at the time we felt that this was emergent. As you know, time equals tissue when it comes to necrotizing fasciitis, and so the correct answer actually is take to the operating room and perform the amputation if necessary. The reasoning is, by my determination, he did not have capacity to make medical decisions or give informed consent, and this was an emergent procedure. So due to that, as a physician, as a hospital, he is considered a vulnerable adult, and we, because we don't have a surrogate decision maker at that time, and we won't be able to get one for quite a while when it'll be too late, the decision was made to take him to the operating room. So I don't know if the panelists, anyone wants to chime in on that? Nope. All right, we'll move on to the next slide. So
Temple, I'll just, this is Leslie. I would just also, I think one of the things that's also good to clarify, usually all of your hospitals will have 24-hour ethics consultation. And so one of those things that this is a good prompt is to make sure when are those information pieces available. But again, I think in terms of that, even if there were an emergent ethics consult, the conversation would probably still go to what is current capacity and the urgency of the situation, and does it fall under that kind of urgent or emergent conversation, but also addressing that moral distress. And I know you've got lots of slides on there too, but I think this is such a great conversation about the complexity of these and the ethics dilemmas related to them.
Thank you. All right, so again, just in general, when I think of capacity is, it's a cognitive assessment. So any physician can make it. A lot of people think, oh, we have to get a psychiatric consult. They can sometimes be helpful, certainly, in collaborating, but you really don't need that. You should feel comfortable and confident making a capacity assessment at the time. And really, it is the ability of the patient to give informed consent. I think that's the easiest way to think of it. So they really need to be able to understand and retain the information, be able to use it as part of making a medical decision, weigh the risks and benefits, and then be able to communicate that decision back to us and give reasoning why or why not they made that decision. Another nice tool, it's called the 5 W's. So think questions to ask the patient: will you explain the treatment we recommend? What is your understanding of how this treatment can help you? What is your understanding of what can happen if you don't have the treatment? What other alternatives are there? And why have you decided to accept or refuse the treatment? So other brief comments, if the patient is determined to lack capacity, realize that it's not just about giving consent, they also cannot refuse treatment because again, they don't have the capacity to give informed consent or informed refusal. Everyone from an ethical standpoint should be presumed innocent until proven guilty. So we should presume patients have capacity, but certainly when issues arise, we should probe further to really assess them. As I mentioned prior, we need to realize that someone who does not have capacity to make medical decisions is considered a vulnerable adult. And it's our responsibility as hospital caregivers, providers, and ancillary staff to protect the patient and do what we feel is in their best interest at the time, unless there is a surrogate decision maker in place. It's also important to note that just because someone doesn't have capacity today doesn't mean they may not have it tomorrow. Like delirium, it can wax and wane. And so sometimes patients need a reassessment of their capacity. All right, so we're going to go into the next example. Miss Collins, 36-year-old female, history of alcohol withdrawal. Friends dropped her off at the emergency department and said she had a big old seizure. In the ER, she was very sleepy, confused, post-ictal, but did have a gag reflex at the time. So she was admitted to the ICU. Here, her heart rate, so she's tachycardic, hypertensive, satting well. So 2 hours after admission, she is now much more awake, but also but still tremulous and agitated. She received several doses of IV Ativan. Despite nurses trying to redirect her, she ripped out her IV and is demanding to leave the hospital. And of course, we get the phone call asking for further direction. So here's the next polling question. All right, what's the next step in management or the next best step in management? So A, place an order for a physician hold. B, file a Board of Mental Health petition. C, document in the chart that you as the clinician do not feel the patient has capacity to make decisions and advise the nursing to call security and if necessary, order restraints if necessary. Maybe some D, have the patient sign against the AMA form and discharge them. And finally, call the police to come and place an EPC hold. I'll give people a little bit of time here. All right. Okay, very good. Ding, ding, ding. So the correct answer is C, document in the chart you don't think they have capacity. For a Board of Mental Health petition, I'll go into that in some of the next slides. The medical hold may be appropriate in certain states, but in the state of Nebraska, we don't recognize a medical hold. I wonder if any of our other panelists, are they aware of that in their states?
Not in the state of Washington.
Okay.
We don't recognize a medical hold.
Okay.
And also not in the state of California.
Okay. All right. So in general, yeah, you basically just have to document in the chart. The EMR we use is Epic. I know not everyone uses Epic, but a lot of us do. The way we do it, just from a practical standpoint, is those physician and nursing sticky notes. That's where we'll put it, that, you know, I have determined this patient doesn't have capacity. That way the entire care team knows that that's the situation. Obviously, if later on they show that they do have capacity, you know, you want to delete that sticky note. Board of Mental Health, like I said, we'll talk about that. AMA would be inappropriate because, again, we don't feel the patient at this time has capacity to make medical decisions. They're tremulous, they're clinically in acute alcohol withdrawal, and they don't, and they've received several doses of Ativan. So at that time, we don't feel the patient has capacity. And the EPC hold is not appropriate because the patient's already in the hospital. That's for what things that occur outside the hospital. All right, so briefly, patients without capacity who want to leave, staff should obviously take all reasonable measures to distract or convince the patient to stay, but the key is to not put themselves at risk and, contact security sooner than later if necessary. Physical restraints or intervention is only appropriate if there's perceived imminent danger and should always reflect the least restrictive measures. So, and then if the patient does elope or leave prior to dismissal, that's the new PC term we're supposed to use, not AMA, leave prior to dismissal, LPD. If they do leave and people find out later, then obviously you need to escalate this to your supervisor, get a hold of security and or local law enforcement if necessary. So what I think a lot, or at least in our facility, a lot of nurses were confused on the whole filing of a Board of Mental Health petition. And not just nurses, but some of the more novice staff. And we realized for that, it specifically needs to be a mental illness, not a substance-induced mental illness. So acute psychosis, alcohol withdrawal would not fall under this. So they have to be mentally ill and also dangerous to self or others. These are the patients that typically we will involve our psychiatry team to help with that. If they refuse voluntary inpatient psych treatment, those are ones that actually go to court, etc. So, but this is generally not something we go to. A couple of our definitions, we've talked about a lot of them. I just wanted to breeze through them again. Capacity can be determined by any physician, but competency or placing someone with a legal guardian has to be determined by the court of law. A judge has to make that decision, and it cannot be reversed by a physician. It has to be reversed by the court in the future. So departure prior to dismissal, that's the new term for AMA. And this is the one that almost notoriously every medical student and resident that I ask to differentiate between power of attorney and legal guardian and what the difference is, a lot of them don't know. Power of attorney, again, would be only if the patient's incapacitated, right? So at the time of your assessment, you think they don't have capacity, you can enact their power of attorney, which usually they've already signed advance directives documentation. Whereas a legal guardian, again, is appointed by the court, can only be reversed by the court, and a surrogate decision maker, that legal guardian is the only one who can do consents, decide whether the patient's code status, etc. Kind of talked about some of these here, and this may vary by state. An EPC, I've been told, is in effect in Nebraska for 36 hours. It's filed by the police, and that's usually prior to them bringing them into the emergency department. Law enforcement custody is, higher up in that. Usually that's someone that comes in as admitted from jail, where the officer is present at their bedside or right outside the door 24/7. Sometimes they're in handcuffs. And we already talked about that. All right, so I'm going to, anything from the panel on that? I think we're good. All right. So next is Ms. Johnson. You'll notice that each of these cases, there's a difference in the urgency or emergency situation. So whether it's acute versus subacute, and that changes what decision you may make as a clinician. And I think Dr. Shaw may speak about that more later in her slides. But realize that it does depend on the situation and the severity at the time, not to make things more gray or confusing, but that is the way it is. So, so this is a 72-year-old female, she's got a history, kind of the usual internal medicine patient, elderly, coronary disease, history of stroke, vascular dementia, diabetes, hypertension, hyperlipidemia, and AFib. And she comes in with atypical chest pain and a mildly elevated troponin. We did a CT of her chest that showed bilateral PE. We did lower extremity Doppler. She's got a right lower extremity acute DVT. We started her on Eliquis or apixaban. The echo did show some regional wall motion abnormalities. Cardiology was consulted and did recommend a Lexi scan, a stress test, for which the patient verbally agreed to have. The primary, the nurses were asking, well, can she sign the consent form or not? The primary physician at the time, myself, did not feel she had capacity to consent for the stress test due to her advanced dementia. And she's still unrepresented. Social work's already on board. We're looking for that surrogate decision maker or guardian to be appointed, but that has not happened yet. And realize that that can take, at least in my experience, a couple months sometimes. So what do we do with these people while they're under our care? So what is the next step in management? The first is A, proceed with the Lexi scan only after a court-appointed guardian signs the consent, but that can take some time. B, cancel the order since they don't have capacity to consent. C, proceed with it, where the physician again documents the patient does not have capacity, but they feel it is medically appropriate. And the last answer is proceed after 2 attending physicians have signed the consent form. And I would argue that there may actually be another answer, but choose the best. Okay, so here, what I had for the correct answer was, and I agree, proceed with the Lexi scan without the consent. You just document that they don't have consent. Again, it's a vulnerable adult. But what's really tricky, I think, about this question is this is not an urgent thing that needs to be done right away, and we don't have a surrogate decision maker. So maybe involving our unrepresented patient committee or ethics committee, that could be answer E. And that would also be, I think, a reasonable thing to do. But I want to open up to the panel because I feel like this one's kind of gray. And what do you guys think?
Yeah, I agree. I think, you mentioned a little bit ago that it is situational. Assessment of capacity is situational, and I know we'll talk a little bit more about that later, but I think it's very important to keep ourselves centered on how quickly do I need to make this decision, right? Do I really need to make this decision in the next 1 hour, or is this something we can take a little bit time, perhaps wait for the patient to clear up a little bit or find an appropriate surrogate? So I feel like, as hospitalists, sometimes there is a tendency, we're constantly trying to do things fast, but these might be situations where we really need to take a pause and see, do I really need to go fast? Can I buy some time safely to really get to the right outcome? So yeah, I don't know. Leslie, do you have any comments?
Yeah, I love exactly what the point you brought up is that in the Midwest division, we have an unrepresented patient ethics review committee, and I believe many of the divisions in Common Spirit Health have something very similar. And sometimes even that, just putting that process in place can give you as hospitalists, especially, additional support, knowing that you are, kind of on your own in this component when there isn't a decision maker. How do you partner to kind of talk about? And one of those first questions I'm always asking is, how urgent does this decision need to be made? Where does it fall in? And then it's always amazing to me, really, how quickly we can pull together those unrepresented patient reviews. I'm astounded at everybody's willingness to participate. But, how fast that is all relative. So we, on the ethics side of things, want to be able to support you all as you're trying to navigate this too, knowing every case is so very, very different.
And I just wanted to say I'm very impressed with the physician who actually said, I don't think this person has capacity to consent to this Lexus scan, because I think in real life, often we just say, oh, she's agreeing. We don't really, we just use that perhaps as the easy way out. So I think it's a great question to consider.
Well, you bring up a great point, and yes, with this particular case, actually, I brought that up because the residents, of course, the residents and the students are like, oh yeah, you know, she has capacity. And again, until you really sit down and talk to these people in depth is when you fully understand, you know, what their cognitive deficits are. And also, I think an important point to bring up is these issues don't usually come up unless the patient is refusing to do something that we as the clinicians think is correct. Usually, yeah, we just say, oh, well, she said, okay, let's do it. But you're right, it comes up more when the patient refuses certain things, such as the next question. So again, little reminder, she has a acute DVT and acute bilateral PE. The nurse calls and says, hey, by the way, for the 4th day in a row, she has refused to take her medicines, including for her Eliquis or her apixaban. So this I would consider, so again, she still does not have capacity to make decisions. And this is more of a subacute situation, right? Like she probably isn't going to die in the next 24 hours, but you know, if more of that DVT were to break off, she could possibly die. So it's more of an urgent, maybe not emergent situation. So let everybody vote. So do you change her apixaban to aspirin? Do you change it to Lovenox, put her in restraints and give her the injection? Do you just DC she's refusing it, we're just going to DC the order? Or do you ask the nurse to crush the pill and put it in applesauce? Or pudding? All right, very good. Yeah, the correct answer is ask the nurse to crush the pill and put it in applesauce, which as I'm just reading these answers, that seems like, I don't know, it sounds kind of funny to me, but that's the least invasive, least intrusive thing to do in a patient who, again, this is important that she gets this medicine. And we're still waiting on that surrogate decision maker. So I don't know if any other comments from the panel on that. All right. Let's see. So briefly, again, as hopefully we've shown through these examples, both hopefully given some clarity, but also made you think, okay, these are very gray areas. And so when you're struggling as a hospitalist or as a provider in these situations, know that there are some, there's lots of tools and resources at your disposal. They may differ from facility to facility, but one thing I always mention is if you want further kind of objective or corroboration, depending on the hospital, sometimes it's speech therapy, sometimes it's occupational therapy. You can ask them to do like a cognitive assessment. I know there's the Allen's cognitive assessment, there's SLUMS, there's MOCA. Those are some of the different ones that I've seen. And again, it's nice to have that just documentation of kind of an objective measure of where they're at that time as far as cognition, especially because if it's an acute delirium down the road, maybe you repeat the test and they're doing a lot better. And at that time they have capacity. So I think it's a useful tool, especially for these patients that may be waxing and waning, or maybe they're in the hospital for a while. Again, I think psychiatry is important. They are very good at assessing capacity. Having said that, I would discourage you from overutilizing them. Really, I involve them. Sometimes it may be a question of, okay, is this acute psychosis due to schizophrenia or depression with acute psychosis, Or is this just a substance induced psychosis, which, of course, should get better with time. So they can help with that. If I'm starting to think about Board of Mental Health type things, that's when I usually involve psychiatry. As social work, of course, can help with that process of finding, trying to hunt down advanced directives, getting them set up with a surrogate decision maker. As we mentioned previously, we have the ethics committee. Most hospitals have an ethics committee. And in the Midwest, we have this unrepresented patient review committee, which I have served on in the past, and it has been really helpful for some of these difficult decisions. And then realize that how, maybe we don't always think of it off the top of our heads as hospitalists, but our palliative care clinicians, they have so many goals of care discussions. It's what they do, and it's what they're really good at. And so I'm going to hand it over to the panel. I don't know, Jennifer, you want to make any comments from your standpoint?
Sure, I'd like to. Yeah, I agree. I hope most of you do have access to a palliative care team, and like psychiatry, we don't want to be the capacity people all the time, but just by virtue of having a goals of care discussion and trying to tease out what they understand about their illness, what is their prognostic awareness, what is their choice, and especially the rationale for it. That it's basic to what we do every day. In fact, that's part of my standard note is, do they have capacity or not? And it's just amazing how many times they don't, or they don't have capacity for a specific decision. And we should always assume capacity, but I think having a framework for really teasing it out and involving their surrogate decision maker or their family and making sure it's very consistent with their values, you can still, even if they don't have capacity, you can come together to a very good decision or a well thought out and a logically consistent decision by involving all those other factors, especially family and people who know what their value system is. And I want to make one other comment. We often, as in palliative care, are involved when there is a conflict between what the clinician thinks should happen and what the patient or family is requesting. And I think that just means we should be very attentive to our personal and professional biases when we're doing assessments. And just because a person with end-stage congestive heart failure and frequent episodes of VTAC wants to be resuscitated or put on the ventilator for the 15th time, we have to really, of course, try to help the person themselves understand if they don't, and really help them elucidate their reasons for wanting that and point out any internally inconsistent either information that they have or how it's not consistent with their values. But we also have to examine our own personal and professional biases. And I think that can be hard, but that's one of the things that I really had to work on when I started doing palliative care. And I still find myself pushing back a little bit sometimes against teams that are in moral distress, but yet if you can explain to them why the patient is deciding what they're deciding, it can help quite a bit with that. And that's all I have to say.
Oh, that was great. Thank you. And I have caught myself in that situation many times with my own personal biases as a clinician. And I think it's just, we all do it. And I think just recognize when we do it, and try to keep our own biases to ourselves. And as you said, try to really understand what the patient's wishes are. All right, so let's see next. I believe it's Dr. Shaw.
Yes.
All right.
Thanks, Temple. So I think one of the ideas or concepts that Temple has mentioned earlier was that decision-making capacity is really based on the situation. So there's a context-based nature of capacity. So let's talk about this particular example. I'm sure we are all familiar with a similar situation. 63-year-old lady with moderate dementia brought in by the police department, just found wandering around, not able to tell her address or any of her family members, living in a tent for several months, able to express her food preferences of what she wants to eat in the hospital, frequently gets angry with staff, found to have hemoglobin of 5.2 and blood glucose of 289. Does the patient have decision-making capacity? So we often find ourselves in this situation, right? We meet this patient, we know this background, and we are wondering how much weight to give to what the choices that the patient is expressing, because do they have capacity or they don't? But that question is kind of incomplete, right? What gives the question a little bit more sense and context is, Temple, if you could go up to the next 4 options, just bring out the 4 options that are there. Yeah, so what are we talking about capacity, right? Capacity to determine what? Are we talking about, does the patient have capacity to order a sugar-loaded beverage? Go back, please. Yeah, to order a sugar-loaded beverage, yes, their blood sugar is high, they have diabetes, and they want a regular soda or something. Do they have capacity to make that decision? Or for declining insulin, or for perhaps declining blood transfusions, or for declining amputation if they're found to have a critical limb ischemia. So each of those questions kind of makes us feel differently about the situation, right? The gravity of the situation makes us feel differently, which is the right way to go about it. Next slide, please. So based on what is the question that we are trying to determine capacity for, it's really important to have the context of, is it a low risk decision or is it a high risk decision? In our previous example, we can consider ordering a sugar loaded beverage as perhaps a relatively lower risk decision, whereas decision about amputation as a high risk decision. So can you just go get the next 4 options, please? So these are just some of the examples that we routinely come across when we are trying to assess decision-making capacity. Appointment of a durable power of attorney. It's considered a relatively low risk decision. There doesn't need to be a lot of technical understanding to be able to do that. So relatively low risk decision. Placement in post-acute care facilities, perhaps a little bit higher risk, but still overall a relatively lower risk decision as compared to when we are consenting a patient for high-risk procedures, or even more if we are talking about removal of life-sustaining treatment. So really, what is the gravity of the situation that we are trying to assess the decision-making capacity for? And just having that context can sometimes be really difficult to really pinpoint that question. It's really important to ask ourselves, yes, I'm assessing capacity, but what am I assessing capacity for? And just adding that context can make it a little bit easier to really assess that, does the patient truly have understanding of what we are talking about in this context? Next slide. So, of course, we've talked about many things, right? I mean, low risk, high risk, capacity can change with time. How much do they understand? Do they understand the risks? And it's a lot. Like in the hospital, it's a dynamic environment. It's when patients are in their most vulnerable state. It's when very high stake decisions have to be made and multiple high stake decisions could be made. So we need some help, right? Next slide. So we here in the Pacific Northwest actually made a mnemonic, which we use as a screening tool, and we call it well scored, because we want to nail it, we want to get to the right answer. So well scored is basically a tool that we've used for hospitalists, more used for as a screening tool, right? So not so much for those really complex situations where we probably need to get ethics involved. But this is more like a screening tool that as a hospitalist we can use. And we feel it kind of captures all the different elements we've talked about up until now for assessing capacity. So the first thing, W stands for, what is the medical decision? Are we talking about ordering that sugar-loaded beverage? Are we talking about amputation? So what is the medical decision that we are talking about? Is the patient able to express a choice? So do they express a choice? And I think this is something we need to be mindful of. Expressing a choice doesn't always have to be the ability of a patient to speak to us. They could point to who they want their DPOA to be, or they could perhaps use a sign chart or sign language or some cue cards or an interpreter. So again, the due diligence has to be done to allow the patient to express a choice. So what is the decision that we are talking about? Are they expressing a choice or not? What is the level of risk for that decision? Is it a relatively low risk decision that we're talking about? Is it a very high stakes, high risk decision we are talking about? The S is for situational understanding. They may not have as much understanding about, like, do they have systolic heart failure, diastolic heart failure, but do they know that they have heart failure, perhaps because their valve is not working and, their doctors are recommending a valve surgery. So do they understand what is the situation that we're talking about and what are the consequences of the choice they're making? So if they're saying they don't want surgery for this valve, do they understand what are the implications? Perhaps the implication is, yes, I'm going to end up being in the hospital again and again because I'm going to keep getting heart failures. Or yes, I could potentially die if I don't do this. So do they understand the consequences broadly? How do they rationalize their choice? I think this is a really important one because sometimes the choices people are making may not make sense to us, but they might have a rationale which takes them to that choice. So an example could be that somebody with a very low hemoglobin might, because of their religious beliefs, say that they do not want to get a blood transfusion, right? That is how they rationalize it based on their values, right? So I think this rationalizing the choice part can get tricky sometimes because it's not, when we are assessing whether the patient is able to rationalize their choice or not, we are not really assessing what choice they're making, but we are assessing the process of how they made that choice. It could be that we are recommending you should go to a skilled nursing facility because, you need more supervision, but they want to go home. And the way they rationalize their choice is that they have always been independent. They've had a poor experience with going to a skilled facility. They feel like in their house, they could walk around even with their eyes closed because they know how many steps they have to take to get to the kitchen, to get to the bathroom. That is their process of rationalizing it. So do they have a process of rationalizing their choice? That's important. The E stands for evaluate capacity. So once we have all the other information, that's when we say that, yes, the patient has capacity. No, the patient doesn't have capacity. Or sometimes we might just say, like, I don't know. And that's when we talk about the other resources that Dr. Anzalone was mentioning. Do we need to get ethics involved? Do we need to get psychiatry involved? Can we get some input from speech or from palliative care? So it's okay to say, I don't know based on this information. This is just to be used as a screening tool. The last one, D, stands for date and time. So again, like we mentioned earlier, that capacity can change. Patient does not have capacity today, but they may have capacity tomorrow. So it's really important to say, when was capacity assessed and do we need to reassess it? So we found well scored to be quite helpful. And if you can go to the next slide, when we compare well scored to some of the previously existing criteria for assessing capacity, I know this looks like a busy slide, but the ones in orange are the two criteria which are previously existing. And well scored pretty much captures all the elements that are covered in the previously existing criteria and just probably adds a few extra items such as like date and time and what is the decision to be made. So we feel well scored is a pretty comprehensive tool for our system here in the Pacific Northwest. For the Hospitalist, we have made well scored into a dot phrase that can be used in our notes. So just as a decision-making tool for providers, and we found it to be very helpful. So I'm going to hand it over to Leslie to take it from here.
Great. Thank you so much. It's been great to listen to everybody. And I love that last tool. I'm even thinking of some opportunities just to ethics perspective. I think a couple of things just to highlight that I think are important to think about. One is that how hard it is to be able to recognize someone doesn't have capacity, but is adamantly saying no, kind of like the original case study, but also how easy it is for us to maybe fall into that thing of, well, if the patient's agreeable, we don't really question capacity. And so I think that was such a great thing to bring up. I think also the language that we use is so important, whether it's competency or capacity, but also whether it's looking at things like how we're using the terminology of surrogate or power of attorney or guardian, because there's so many implications about those. In fact, guardianship should be something we refer to very cautiously because of the long-term ramifications and limits it has on people beyond the healthcare setting, when perhaps we're using that simply as a word, when what we mean is we just need to identify a surrogate decision maker for the patient. And so those are some really key components. I think also thinking through the kinds of things that we look about in terms of the multidisciplinary perspectives that can be brought in, basically to help you. I first originally started to think about the unrepresented patient process and formalizing it while talking to a hospital medicine that said, I feel like I'm alone on the island of decision making for this patient who's so vulnerable, and I want to have other perspectives. And so where you have those processes in place, that can be incredibly helpful, hopefully to support you and the team as much as to support that extremely vulnerable individual whose voice is not able to be heard. And I think the other thing is to remember, as was mentioned here, capacity and the ability for a person to have input into their decisions is that sliding scale. It varies over time. And even when a patient may not have capacity or full capacity or that ability, I love the well-scored chart, that ability to be the only or primary decision maker, what they're saying matters. And how do we contribute that? Is it consistent? Is it something that reflects something they've had a conversation with during last hospitalization or what have you? What you see here is a tool that we've developed and are working on to have available for across all of Common Spirit Health. It's our patient-centered decision-making flowchart. We all have flowcharts, and I know that this is hard to see, but I can definitely provide this to all of you who want this. This is a nice flowchart that talks about capacity assessment, when the patient has capacity or not, and how do we work through those processes. And even in the middle of that implies the unrepresented patient process. And Temple, if you'll go to the next slide. It's a very hard slide to see, but it's a slide that I want to share with you all because it is basically encapsulates a lot of what we've talked about here today. And the reference guide, if you get this either electronically, in our division, we have little laminated versions of this for references, talks about language. It talks about some of those questions to assess for capacity. And Dr. Shaw, I'm going to work with my component in the Pacific Northwest to see if we can build the well-scored tool into this, so it's a nice reference guide as well. And you'll see on the right side of this document, it has some of those things like who is that surrogate hierarchy by state. And Temple, I'm going to go to one next slide I put in probably 2 minutes before, so I don't know if it's even in the slide deck, but if you could advance the slide. This, what you see here, we're developing out of the ethics team, an interactive map that will have a version you will be able to go into, click on your state, and it will have all of the state relative information. That basically those last two slides in that component that you'll have available, and we'll make sure that that information gets out to all of our hospital medicine teams, as well as anybody else who would be interested in this, so that you have interactive reference guides to be able to guide you through some of those questions. Because again, we want you to feel supported as much as you're trying to support your patients in the middle of those really tough decisions when they aren't able to make their own decisions. I really appreciate everything you all do. And I want to reinforce, certainly however the ethics structure, committees or consultants or the VP and the national teams can help you to develop tools or to be resources for you. We're definitely happy to navigate these tough journeys with you, especially in cases like those you heard of today and in so many more we could think of. And I'll turn this back over.
And in the interest of time, I'm going to summarize some of the questions. The first was, I think it was kind of more of a clarification than a question. We want to make sure that everyone understands that for APPs, determining capacity is in the scope of practice of APPs. That doesn't mean that you need to be aware of state laws Probably it would be rare that the state law would get in the way of that, but certainly your bylaws. You have to be aware of those types of things, but in terms of scope of practice and training, it is certainly within the scope of practice of an APP. The second question was about publishing the well-scored tool. We will make sure that everyone on the webinar gets a chance, and we'll also publish it out in other ways. There was kind of an involved question about the unrepresented patient process, and I think we're going to have to take that one offline. And Leslie, in the last 30 seconds, I'm going to ask you a question. If there is a facility that doesn't have access to an ethics committee, is there a common spirit health way to get help from an ethics committee from a different location or division? And I'm afraid that Leslie is frozen. I thought that was an important question. We'll make sure that we get the answer
There
to
is,
that.
I'm
Oh,
having
you're
trouble with my
unfrozen.
unmuting.
Get the answer. Oh, you're unfrozen.
There we go. Is that, oh gosh. Hi, okay, I think I'm unfrozen now. Sorry about that.
Yeah.
On the ethics consult site, missiononline.net/ethics, you can get an ethics consultation. I'll tell you the easiest way to do that. If you would, I think I may be frozen, you can reach out to ethic or to me, leslie.kuhnel@commonspirit.org, and I'll make sure to get that answer out to everybody. The National Ethics Team has an availability for ethics consult service, and we'll make sure that you know who to respond to and how to get a hold of that person. And we'll also be sending out some more information about those resources that we're developing to help you.
Okay. Thanks everyone for joining. It is the top of the hour, and especially thank you to all of our panelists, and have a great rest of the day and rest of the week.